reassessment. Why don't we reassess a patient?
Make sure the condition hasn't changed.
Yeah, because what's the D word? They are dynamic. They are changing. That's right. So we're going to look at how to perform the reassessment. We're going to look at recognizing significant changes in the vital signs. And we're going to look at the difference in the reassessments between a stable patient and an unstable patient, because they're slightly different. Okay, you got your sheets out, right? All right, so our reassessment really is a continuation of everything that we've been doing. We start back over with our initial assessment, because we're mainly looking for changes, but also any trends as the patient is slowly either getting better or getting worse, but any other changes that may occur. So we're looking for changes, trends, if they're deteriorating or getting better. And all of these things that we identify, we're going to document. That means we're going to write them down. Okay, when you're doing your reassessment or even your initial assessment, any part of your patient assessment, you want to make sure you talk to your patient, because it can be very disturbing. They're already upset, they're concerned, they're worried, they're stressed. And by you describing what you're doing before you do it and while you're doing it, you may comfort them and actually you help their vital signs. They're going to feel, oftentimes they're going to be embarrassed because you're going to have to check areas that you may have to expose. So always tell them what you're going to do before you do it, and try to ask permission, because they can always, decline any treatment or any assessment that you want to do. So if it's something that you feel like there's a comfort issue there, ask for permission and explain to them why you got to do it. Okay, we begin our reassessment by repeating our primary assessment. What's in the primary assessment? What's the first thing in the primary assessment? Starts with the G, general impression. That's what we just took that little quiz on, right? Okay. So it's going to be checking the general impression. And then what? We're rechecking their level of consciousness. Has it deteriorated? Has it gotten better? If you've got a patient with hypoglycemia and you've given them some oral glucose, what would you expect their mental status to be?
Better.
Yeah, it should be getting better. So in our initial assessment, we found out they had a diminished mental status. We checked their blood sugar, we gave them some oral glucose, and now they're doing better. So mental status, are they getting better, are they getting worse? All right, what's the third part? Chief complaint. And you're not just asking them what's your chief complaint, where does it hurt? You're asking them specifically about that chief complaint. If your patient had complained of chest pain, you've gone through all of your assessment, your treatment, you've given them an aspirin, you've given them oxygen, you've given them some nitroglycerin. Now you say, okay, how's your pain now? Are you feeling better? Have you gotten any new complaints? All right, so what's going to be the next part of your initial assessment after that? Airway, yeah. Y'all don't be shy, you should know this. Right, it's going to be airway. So you want to make sure their airway's still open. If they've gone unconscious on you, they've got that diminished mental status, you're going to have to recheck their airway to make sure they're still able to breathe. Make sure they're still breathing. All right, so what's the next step? Yeah, are they still breathing? Are they breathing adequately or inadequately? And what's the next step? Circulation. And you're checking not just for any blood anywhere, but you're checking what? Their pulse, the character of their pulse. What else are you checking? Their skin signs. Anything else?
Shock.
Yeah, you may have to treat them for shock. If you've treated them for shock, is that helping them or not? So you're going to repeat your primary assessment. And you go through all of those steps because it's very easy for your patient to change, and you could easily not notice it. You may have to change your patient priority. So you've gone all the way through your full assessment, and then you come back for your you're repeating your primary assessment, and they've deteriorated. Well, it could be you had started out just driving with traffic in the ambulance to the hospital, and now they've gone unconscious. You want to ramp that up, right? So you may reestablish. You may be halfway to the hospital, and your patient, turns really sour on you. You may call for the helicopter and meet him somewhere in between if you feel like that's what you need to do. So you may have to reestablish your transport priorities. Okay, other things you're going to reassess. You're going to reassess their vital signs because we're looking for what? The T words, trends, that's right. So we're going to compare everything with our baseline set of vital signs that we've got. We're going to reevaluate as part of our vital signs. We get a pulse oximeter, right? What about if we had a patient who was hypoglycemic, we did a sugar stick, we gave them oral glucose? What part of vital signs would you want to check right here? This is an easy one. Yeah, let's recheck the sugar. How about that? Let's do a second sugar stick to see if their blood glucose levels come up or not. And once you've done that, you want to make sure you document it because you will forget it. And I know I forget everything, but even you with your tender, fresh little mind, you're going to forget stuff because patients start to all look alike and numbers are all alike. There's nothing different about a blood sugar of 47 and a blood sugar of 56. They're still low, right? Are you going to remember those specific ones? You might not. You might not. So get in the habit of writing this stuff down. Think of an example of a problem that might develop into a life threat to the patient on the way to the hospital. Cardiac arrest would never be good. Chest pain, now they've gone unconscious, now they're in cardiac arrest. What are you going to do for that immediately? Yeah, you're immediately going to start chest compressions, right? So yeah, there are a lot of things that can deteriorate very quickly. Mental status is one of those. You know, as we've talked through all of our assessment up to this point, remember we've mentioned that mental status is going to be one of the things that's going to tell you, are they getting proper oxygen? I'm not going to say it tonight. Are they oxygenated? How's that? They've got enough oxygen in their bodies. It may tell you if they've got a head injury. It may tell you if they've got a drug overdose. So mental status is very, can change very quickly. Anaphylaxis, we haven't talked about that yet, but that can get worse. It can return. Respiratory rest failure could turn to arrest. So after you've done or repeated your initial assessment, you recheck your vital signs. Now, if you have, what kind of patient do we do a focused assessment on? A conscious patient with an isolated complaint. A stable patient, right? So this would be a patient with twisted my ankle or my stomach hurts, where you really can just focus on that one area. This wouldn't be the patient that fell out of a helicopter or something, right? Unless it was, on the ground. Okay. You want to continue to ask your patient, what's changed? Do you feel the same? Are you getting better? Are you getting worse? Are you noticing anything else? If it's a trauma, they may have developed aches and pains somewhere else. How many of you have ever been in a rear end collision, where you've gotten the whiplash thing? Oh, I'm sure a few of you have. You feel okay at the time, and then by the next day you're like this, you can't hardly move. So yeah, your patients are dynamic, so they make it worse or make it better. You want to repeat your physical exam of that focused area, and then identify if it's changed from your initial assessment. So it's going to be repeat your focused assessment. You also want to recheck any interventions. Remember last night y'all were doing long bone and joint, that kind of stuff? Those are one of those things that does change a lot. You put a splint on a patient, you feel for a pulse, you check the temperature, everything's good. You check it 15 minutes later, and now we've got no capillary refill. The hands are cold. They're starting to turn kind of purple on here. What's happened with that? Yeah, how'd we do that? We may have wrapped it too tight, or we might have wrapped it well the first time, but it swelled quite a bit very quickly after that. And now we've got a problem. We're going to have to loosen that, right? So you're always going to have to recheck your interventions. If you put your patient on a non-rebreather mask, you filled up the bag and everything's good, you set it appropriately. What's the appropriate setting of oxygen flow for a non-rebreather? The range is what? 12 to 15. Yeah, if you put it on 12 and you check back during your rechecking your interventions, because putting them on oxygen would be considered an intervention, you recheck it and you see that every time he takes a breath, it flattens down. Now, what if initially when you put it on, it wasn't flattening down, and now 10 minutes later, every time he takes a breath, it goes flat? What are you thinking about that? Better or worse? Yeah, he may be breathing worse. He might be breathing heavier, taking deeper breaths. Because before he wasn't sucking that thing flat, but now he is. How would you manage that?
Turn it up, actually.
Yeah, turn it up, crank it up to 15. And then you might try to determine why he's like panting or whatever his issue is. See if you can get him to slow his breathing down or whatever. But yeah, recheck all of your interventions. This is just repeating your focused assessment. So we'll do a focused assessment on anybody that has an isolated injury or complaint, but you also will repeat your physical exam if it's like a multi-system trauma or one of those general complaints. I just don't feel good. You know, where you might have done a full body assessment, you will come back and do that again. What if it was something like, you know, an insect bite and they didn't realize they'd been bitten, or a snake bite and you didn't catch that initially because it wasn't swollen? You come back after doing your assessment with your repeat assessment, and now that area is swollen or getting numb or tingly or whatever. So you always want to do a complete reassessment. When would you not do a good reassessment?
When you know how.
Okay, just because it's a significant mechanism of injury, you're close, but not all the way there. You have it, Lisa? Come on, spit it out.
Like that.
Saving the life when they're sucking up, oxygen in their throat or something like that, and they have time.
Yeah, if you're trying to manage their ABCs, you know, keep them alive, then you're not going to waste time on a reassessment. You're going to be focusing on ABCs. So when you look at this, the trauma sheet, or the medical sheet, it's really an order of importance. You know, that initial assessment, that primary assessment, that is the most important thing. If you're stuck in there somewhere, if you haven't managed the airway, you know, you can't go on to those other steps. You're stuck there until you manage it. It's just like in CPR when you're doing choking. If the patient is choking, they don't have an airway, what can you do for them? You've got to work on the airway. You can't do anything else until you clear the airway, because they're going to die from no airway. So you're stuck at that point until you can accomplish it and be successful. Always recheck your oxygen. Could be you've run out of oxygen. That's extremely common. If you're using a portable oxygen tank, you've taken that into the patient's home, and for whatever reason you get caught up in there and it's taking you longer than you thought, and you look at your patient and all of a sudden the bag is flat and they're starting to, you know, roll their eyes back. You want to recheck your equipment. You've probably run out of oxygen and he's just sucking nothing but his old breath, and you know, that initial 21% with every breath is going to diminish, right? You want to recheck your bleeding if you've done any bleeding control to make sure that bleeding has stopped. It's not continuing to bleed through anywhere. And any other interventions that you've done. Can you think of an intervention that might need to be reevaluated, and discuss your process for examining it? Talked about 10 of those, right? Which would be the most important? Yeah, it's going to be your airway and breathing. Those are going to be at the top of the list, certainly. Ta-da! Okay, our reassessment also, as we said, is we're observing for trends. So we want to reassess on a regular basis, depending on how bad they are. If they're real bad, how often should you reassess?
Every 5 minutes.
Besides often, yeah. Every 5 minutes. If they're pretty stable, how often do you need to reassess?
15.
About every 15 minutes, that's right. And there may be times where you have to reassess more frequently. Make sure you look at your vital signs. You might not notice the difference between a systolic pressure of 120 and 102. 102 sounds fine, 120 sounds fine, but when you put them side by side, within 10 minutes your patient's gone from 120 to 102. How are we doing here? Not real sure till we get one more, probably. If he's down in the low 90s now, he's going bad very quickly, right? Could be he normally keeps a low blood pressure and he was nervous and upset and it ran it up to 120 and now it's dropping back. So you've got to observe it more than just once or twice. And then based on what you see, you may alter your treatment. You know, if he's real tachycardic, he's tacking along at 120, his blood pressure is, you know, 96 over 68, what kind of treatment might you do for him? You've given him oxygen, right? What else would you do for him? vital signs like that tell you? How's he doing? Is he within normal limits on his vital signs? 140 is never good. Remember I told you the cutoff was, we can tolerate tachycardia up to, about 120-ish. Once you start getting above that, your heart's not able to fill and get a big enough pulse out to maintain the blood pressure. So he's basically in what? What's the term? Starts with the S? Oh, thank you. That would be shock. How do we treat shock? Oxygen, a blanket. Yeah, you may lay them down, position them. Yeah, that's how we treat for shock. So, yeah, we might make some adjustments in what we're doing based on that. How long we're with the patient may determine how often we check vital signs or how often we reassess. As I mentioned to you, in the state of Alabama, you have to document at least 2 sets of vital signs. If you're 5 minutes from the hospital, you better make sure you get one on scene, and then you get one just as you're getting out at the hospital, even though you might only be with them 7 minutes. If they're stable enough, you still need 2 sets. So the more serious they are, the more often you're going to reassess. There will be patients where you're constantly reassessing them. You're working on their airway, you're working on their breathing, you're going to be constantly reassessing them. Their mental status is deteriorating. You have to constantly do that. So that. Anytime you recognize that the patient's condition has changed, you want to start right back over with the initial assessment and do that. Okay, the stable patient, you'll repeat your primary assessment, get your vital signs, talk to your patient. Has anything changed? Any more pain, less pain? Anything I can do to make you feel better? That kind of stuff. Repeat it every 15 minutes. If they're unstable, it's going to happen much more quickly. You're going to be reassessing your primary assessment repeatedly, your ABCs pretty much the whole time. You also, though, if you have time, you'll reassess any interventions that you've done. You'll reassess vital signs. But the main thing is going to be maintaining their ABCs. And then you'll recheck them at least every 5 seconds. It doesn't mean 5 minutes. Doesn't mean 5 seconds. Yeah, you guys are really good. That's where we are. Okay, reassessment is at the bottom of your page. That's your last step. And reassessment means what? Return to the top and start over again, right? Because we're constantly reassessing our scene safety, right? That never ends. It doesn't end just because we've done an initial scene size up. Your scene size up never ends. Scene safety goes the whole time. Scene size up changes too. It may change. What must you do if your reassessment turns up one of these findings? Gurgling respirations, what do you do? Good work. Got the answer. If the bag on the non-rebreather mask collapses when he inhales, increase the oxygen flow. What if they have snoring respirations? Open the airway. If they're unconscious, what are you going to do? Put an OPA in, right. See, look again, that reassessment. Not too bad, huh?